May I invite Dr. Prem on the dais? We are definitely out of time, so I will save the introduction. Prem, you can start your session. Thank you.
So good afternoon, everybody. I'm sure everybody is hungry. So I hope I can start some thought process with this and you can get more energy and think about it more during lunch. So geriatric oncology is basically a new frontier, maybe not, but something which has to be looked forward to. We all know that 524 million Indians, 524 million people globally are going to be above 65, were above 65 in 2010. By 2050, 1.5 billion is expected above 65. So the reason it's 65 years and older, because abroad is what is taken, in India it's above 60. Nearly 80% of the individuals older individuals actually live in low and middle income countries, which we usually come into, LMIC. So in 2011, older persons constituted around 8.6% of India's total population, equaling around 103 million. In 2100, it is expected to at least be 20%. So that's a big jump. Then equaling, 2050 around 319, there will be a tremendous impact in the global cancer burden. So one has to understand that people are living longer. So people who are living longer are also unfortunately getting more of cancer. The ICMR cancer registry showed that the cancer diagnosis will increase for almost 1.39 million in 2020 to 1.57 million in 2050. And in Tata, which has done quite a bit of work in geriatric onc, 34.2% of the total number of patients registered are above 60 years. So that's a big number. So if you see, aging more than 60 is increasing and it's progressing both male and female. If you see clearly, female is more than male. Males tend to suffer and die earlier. Females tend to be maybe at peace after males die, but they have other issues, like they will be lonely, they will be single, and they had other issues as well. Now, trends in cancer, if you see, as you see more towards the left, there is obviously more and more increase in the population, which 60 to 64, 65 to 69, 70 to 74, and more than 75. So geriatric oncology in India is actually in infancy, or you can also call it as oncogeriatrics, like how earlier we talked about orthogeriatrics. The majority of the older Indian patients with cancer are not evaluated systematically with a validated assessment, but rather clinical judgment, which is something we have always used, is used for them. So this was a survey of geriatric assessment done for practicing oncologists in India. So in that, almost 70% of the survey people said we relied on intuition for management, and less than 10% used the validated tools. Although 99% of the people actually cared for older patients, but 87% were almost more than 10 per week. 51% did not do the routine geriatric assessment as well. I am not saying CGI, I am saying geriatric assessment. Additionally, 44% were unaware of the American Society of Clinical Oncology, geriatric oncology guidelines, which are very much there. So what about geriatric oncology in India? So Tata Memorial Hospital was pioneer. I am with Mumbai Oncocare Center. Kochi has Medical Trust, which has been doing very good job, but nicely and silently. And other centers are also there. More and more people are wanting to take this up. So understanding the basics, if you see geriatrics, we are usually staging in the aging. Geriatric syndromes, geriatric assessments, shared decision making. What will be geriatric oncology? Staging the tumor and aging. So it will be CGA, geriatric screening tools, along with chemotherapy toxicity tools and prediction tools. What is oncology? From the oncologist perspective, it will be pathology. I have to stage the tumor. So pathology, imaging, performance status, what is the goal of care? So what is the complexity of managing cancer in older adults? If you see this, I'm not going to go through the normal changes which happen, which is very well evident by this article on the left hand side, on the right hand side. But on the extreme left, you can see complicated comorbidities, reduced organ function overall, increased risk of chemotoxicity, increased risk of complications with surgery, Then radiotherapy, lack of social support. We always keep thinking about the person, but what is the social support? What is the quality of life with and without treatment? Psychological distress. Are they depressed, anxious before even talking about the cancer? Polypharmacy, interactions, errors, nutritional problems, both extremes, with and without cancer here, of course. Cognitive impairment, caused a lot of times by chemotherapy, but might be there beforehand. And impaired function. So, these is the complexity. Now, as we all know, older adults are very heterogeneous. So, they go from fit to frail. So, fit people usually will have a good life expectancy, good functional status, good organ reserve, and focus will be on survival. But there is another variety of older adults, that is the frail one. So, in this, they will have comorbidities, they might have polypharmacy, and the toxicities risk. So, the focus will be on quality of life. If you can see the game of Jenga on the right and the left, that's how heterogeneous it can be. So then, of course, let us not always think about treatment. There is something known as under versus over treatment. Under is benefits of cancer treatments are there, but treatment is not offered. Why? Because patient is 90 years old, too old to take it. Then over treatment is there, where in spite of maybe knowing that there is a risk, people end up giving. So under treatment, less intensive treatment, and fit older adults thinking maybe it would not work, not providing non-oncological interventions, especially the geriatric interventions. Then over treatment of a cancer in an older person who's not likely to have, who might not actually have the symptoms in the lifetime. Intensive treatment in a vulnerable older person in which it's too risky. So usually it's to do no harm in both ways. So under as well as over treatment, and maintaining quality of life and dignity in living is very important. So this is how a geriatric oncology multidisciplinary evaluation might look. So geriatric assessment, the core of this group is actually the geriatrician. The reason I am saying is it will be the central point, wherein of course the oncologist will be treating the oncology part, but the geriatrician will be doing assessment. But team members including psychologists, occupational therapists, physiotherapists, dietitians are very, very essential. Quality of life has to be seen. There is something known as non-oncological life expectancy. There are indices online. Then chemotherapy risk, and most importantly is patient and caregiver expectations and treatment goals. A lot of time in India, the person doesn't even know they have cancer, so it can become very difficult. So what about impact of geriatric assessment in this particular article, which is from Tata? So it was seen that it changed to almost 40% of the older adults with cancer systemic chemotherapy plan was actually changed. So following the assessment, there was of course change in almost 40%. Commonest change was de-intensification, but there was also de-escalation and maybe even increasing. Now, in curative settings, there was de-escalation, and patients also had an escalation. So don't think that when we do an assessment, we are not going to treat always. That is that's a very bad myth to think about. Then higher chance of a change in treatment following GA was seen in age 70 and 79 years and above 80 years, and patients with a PS of 3, which is performance status, and people who had more than 10% weight loss. Now, what are the commonly used geriatric screening tools? We often are told by oncologists that there is hardly time. Yes, we agree, maybe they don't have time, but we do. So we should be getting the patients for helping them out. But it helps if they do screeners. So WES 13 is one, then G8 is one, triage risk screening tool is one, Groningen frailty, fried frailty criteria, abbreviated CGA is one. I am not going to the details of the same. These are well available online. You can check it out. Then there was an article in which G8 was compared with WES 13 and CFS. And I'll go directly to the results. It was seen that if you see for frailty, CFS is a good screening tool in an Indian person with cancer. So we should look at, of course, increasing the body of literature. And we all know that doing a clinical frailty scale is not very difficult. It's very visual. You can do it quickly. Then psychological problems. This was another in which it was seen that people with poor ECOG, poor undernutrition, fatigue, higher disease stage actually were associated with an increased risk of screening positive with the anxiety scale as well as the depression scale. The most common psychiatric disorder was adjustment disorder, followed by depressive episode, insomnia. Make no mistake, people in Tata do not belong always to Tata, to regions in Mumbai. They actually come from out, so they have to adjust to a lot of things. Then depressive episode and of course insomnia. A total of 33% of these patients were referred to the psycho-oncology clinic. However, not everybody went to them. So that is another unfortunate part. So in the older Indian patients, we have to look at adjustment disorders, we have to look at depressive episodes, we have to look at insomnia. But again, further studies are needed. So the N needs to be increased. This of saying is that study should happen at multiple centers, because just looking at one cohort of Tata is not fair. So coming on to why we are talking about abroad scales when we have an Indian scale. So there is a scale which was developed by AIMS, by Dr. Joyita Banerjee, was the first PhD in geriatric onc. So she made a prognostic tool of scope C. The short geriatric scale, you should check that out. So in which it was helped in basically enhancing the quality of life. And if you see, it's developing a cost-effective care plan. So score of more than or equal to 66 in males and more than or equal to 60 in females, you can do standard treatment. Then males 49 to 65 and female 41 to 59, reassessment. And of course, palliative in this. Again, it's a screener. Please do screener and clinical judgment. That would be the best, rather than thinking only screener is hard. But it's a good thing, very much adapted to the Indian context. Now, what are the reasons to refer an older cancer patient to a geriatrician? Asserting of an overall health status across physical, functional, and psychosocial domains is done. Secondly, evaluating the potential risk and weighing the benefit of various treatment operations in the light of the outcome of the assessment. Thirdly, optimizing a patient's health status prior to treatment initiations. Assessing a patient's ability to provide informed consent. A lot of times, a person will not have the cognition to give consent. Then, clarifying a patient or caregiver about the uncertainty regarding treatment preferences. Now, a lot of times people come and say that I don't want chemotherapy. Why? Because it's an injection. But they're okay with taking chemotherapy when it is a tablet, because it's a tablet. So it's not necessarily that they understand both work maybe in a different way, but one is superior than the other. Then advanced care planning. I think that initiation is very important. One has to understand older person with cancer will be thinking about the inevitability, maybe the suffering, maybe the inevitability of death. So that advanced care planning is very important, so that the oncologist and us know what we need to do if the person gets worsened. Then potentially relevant questions that we should be asking as geriatricians. How does the cancer currently affect the patient's health status? What is the likely trajectory of the cancer with and without treatment? What would be the standard treatment of this cancer type and stage? What are the alternative treatment strategies? Then what are the potential benefits and side effects / complications of these treatment options? And what is the likelihood that this particular patient will experience these benefits or risks? Now, what is the geriatric contributions to decision making in cancer care? Now, suppose we have to support a patient-focused vision along with the multidisciplinarity. Uncover geriatric impairments just to see the tumor is what can be done easily. But if you know the person has a cognitive issue, a depressive issue, fall risk, you can intervene in all that so that the treatment of tumor becomes better. Evaluating a patient's reserve capacity and ability to tolerate treatment, estimation, the life expectancy with and without cancer, and estimating prognosis and risk of treatment-related toxicity and complications. And ultimately, yes, managing, optimizing the comorbidities and geriatric impairments, and taking time to discuss patient preferences and priorities. I think that matters the most. Now, this, of course, is we have started something known as an Asian Geriatric Oncology Society. So you are more than happy to join and grow along with us so that we can actually spread the word of geriatricians and oncologists working together. So what is the suggestions and way forward? So advancement in research, yes, is needed. Integration of telemedicine and geriatric oncology is important, but it can have its flaws. It's easier said and done that a geriatrician maybe can be available online and just do the assessment, but we all know inpatient assessment is always superior than online. Advocacy efforts in geriatric oncology. It is all our responsibility. Even as geriatricians, I would feel that it's our responsibility to actually do more to advocate the subject. Then enhance collaborations. It's very easy to collaborate with others, global leaders also. Shared decision making, I think, is very, very important. Remember, oncogeriatrics is the collaboration which is best for the holistic care of the older adult. So I see it from this perspective. If an oncologist is treating an older patient, does the oncologist think that this is the best optimum care? No, we as geriatricians should make sure that they realize that when a geriatrician is involved, that is the best possible care which has been given. Another thing you need to understand is we are always asked that what about the overall survival? Will a geriatric assessment better overall survivor? How? It's a very simple question. The reason is we are not giving the chemo or we are not giving the treatment, but it will always enhance quality of life. And that is something we should focus on. See, geriatricians always practice precision medicine. Now, this came up in our conversation yesterday. The reason why we precisely have to look at every point in the problem list for an heterogeneous older patient. And it takes time, but it's actually, we are learning more than the person benefiting more. Then, to all budding geriatricians, please remain patient and give all the respect to your beloved older adults. They not only have earned that dignity, but they experience this through their lifetime. Thank you. Thanks for your patient hearing.
Thank you, Dr. Prem, for exhaustive talk. In fact, he just mentioned that we were a little silent at Medical Trust about the geriatric oncology services. I'll just take a minute to explain that. We started geriatric oncology services in August 27th, 2022. As of today, we have covered around 300 patients, and we started on a very small CME basis right here at IMA. That was called Golden Years. With due respect to all our senior faculty, we had an amazing turnaround of around 200 physicians who came for the conference. And as of now, we have a dedicated oncology team, geriatrician Dr. Gino himself. I head the Department of Medicine there. And we have specialized counseling teams, PROs who handle them, occupational and physiotherapists to help them out. In fact, they've streamlined the therapy to such care that, in fact, even when I come across in my own day-to-day practice, I involve them as a part of the team, and the results are fantastic. So I was just asking Gino about a particular patient who actually had a double malignancy, multiple myeloma with a prostate cancer, but he was very diligently counseled by the team. And even yesterday when he came back, I was wondering what was my role now, and he just came to tell her thanks. So those are the gratifying low-lying fruits of our labor. And as you said, it's about streamlining and optimizing therapy. And I'm sure Gino can add on to this if time permits later. Thank you.
So very happy to hear your talk, Prem. It's just that I saw you have started AGOS and very impressed with the work you are doing right now. I just wanted to understand the basic formalities you are having with advanced care planning. Are we looking forward towards certain policies with DNA CPR like we have it in the UK? Are you working on that? Because already two budding oncogeriatricians living together. So are there any policies coming up? I want to understand that.
Yeah, we are also looking into that, because ultimately as a geriatrician, it's all continuum of care, and the continuum of care is till the person dies. And if possible, if we can get access afterlife, then sure to that as well. So I think that is where we are looking at. We are obviously trying to make sure that we are able to work closely. I mean, the living will is already here, which helps. But in India, most of the time, we are a reactive society and not a proactive society. So we are trying to even enhance that through advocacy and try to tell people to look into it rather than reach to it, which might happen if they have a disease.
Yeah, because clinical frailty scale already you have introduced it, and most of the people have been sensitized now. I'm very happy because I think throughout the conference, clinical frailty scale has been upcoming quite
absolutely.
a few.
And it doesn't take
so
time.
that will tell really how much is the mortality and how much time span has been. So with that advanced care planning, hand to hand makes an easy way to go forward.
Absolutely.
Thank you.
Yeah, Gino. Some comments here. Come on.
I think what Prem highlighted is the take-home message. Geriatricians practice precise medicine, addressing everything. I mean, like comprehensive but precise. That's what geriatrics is all about. And when it comes to geriatric oncology, precise medicine from the oncologist is definitely going to happen. But precise prescriptions for the other comorbidities, addressing their multiple medical issues, optimizing them to survive free of cancer, and making them, the post-cancer period fruitful. I think that's where we intervene a lot and we make a difference. Thank you.
Thank you.